Welcome to Clinical Neurology Podcast, where you will learn over 12 episodes how to localize a lesion in neurology based on history taking and physical examination. The podcast is meant for medical students and to make them enjoy learning neurology. Medicine, pediatrics, psychiatry, critical care, neurology residents, general practitioners and nurse practitioners will find it beneficial. Study materials and clinical resources for the podcast are available in show description and at neurologyteachingclub.com website. I am your host Dr. Krishnadas NC, and let's get started. In this session, we will discuss the clinical localization of sensory symptoms. We will learn the sensory pathways and study the clinical features of lesions involving them. At the end of this session, we will be able to tell the parts of various sensory modalities and the arrangement of fibers in each, clinical features of lesions at different sensory levels, and to localize from the patient's symptomatology where in the sensory pathway is the lesion. The primary modalities of sensation, including touch, pain, temperature, joint position sense, and vibration, are recognized at the level of the opposite thalamus. So all these sensations are carried to the opposite thalamus by the sensory pathways. The fine touch, vibration and joint position sense ascend in the posterior column medial lemniscus pathway, while the pain and temperature through the lateral spinothalamic tract. From the thalamus, they are then projected to the sensory cortex in the postcentral gyrus through the posterior limb of the internal capsule. The sensory cortex helps identify the cortical sensations, namely tactile localization, 2-point discrimination, graphesthesia, stereognosis, and sensory attention. The sensory symptoms can be classified into two: positive sensory symptoms and negative sensory symptoms. The positive sensory symptoms include paresthesia, radicular pain, allodynia, girdle-like sensation, etc. Paresthesia is an abnormal spontaneous sensation felt in the absence of a stimulus. Allodynia is a pain response to a stimulus that is not usually painful. The negative sensory symptoms is one where a normal sensation is not perceived. Negative sensory symptoms include anesthesia, where all modalities of sensation are impaired, and the wash basin sign, which is the tendency to fall on closing eyes, the symptom equivalent to the positive Romberg sign. Sherrington classified the sensory system into exteroceptive, interoceptive, and proprioceptive. The exteroceptive sensations provide information about the external environment. It includes general somatosensory functions like touch, pain, and temperature, and special senses, namely vision, hearing, taste, and vestibular. The interoceptive sensation provides information about the visceral functions, including blood pressure, blood composition, etc. Proprioception includes information about the orientation of the body and limbs in space. The exteroceptive sensation. The exteroceptive sensation originates in the peripheral receptors in response to external stimuli. There are four main general somatic sensations. They are pain, temperature, touch, and joint position sense. Touch. The receptors for touch sensation includes free nerve endings, Merkel cell endings, and encapsulated nerve endings such as Meissner's corpuscles, Pacinian corpuscles, and Ruffini endings. The Pacinian corpuscles acts as rapidly adapting mechanoreceptors and are especially sensitive to high-frequency vibration. Others are slowly adapting mechanoreceptors. Light touch sensation is conveyed over large myelinated peripheral nerve fibers to unipolar dorsal root ganglion cells. Tactile sensation follows several different pathways within the central nervous system. The central process of dorsal root ganglia enters the spinal cord via the medial division of the posterior roots. It then projects through the ipsilateral posterior column to reach cervicomedullary junction. The fibers from the sacral area will be arranged most medially in the posterior column. The lumbar will be just lateral, followed by the thoracic. The cervical fibers are lateral most as they are the last to enter while going up. The second order neuron lies in the cuneatus and gracilis nucleus at the cervicomedullary junction. All the fibers below T8 are grouped in the fasciculus gracilis. Fibers above T8 forms the fasciculus cuneatus. The second order neurons in the nucleus cuneatus and gracilis project to the opposite thalamus. They immediately sweep anteriorly as the internal arcuate fibers and cross over to the opposite side at the cervicomedullary junction. It ascends in the brainstem as the medial lemniscus to reach the thalamus. The third order neuron lies in the ventral posterolateral nucleus of the thalamus and projects to the sensory cortex. The fibers that carry crude touch synapse after entering the posterior horn. The axons of the second order neuron cross the opposite anterior spinothalamic tract and reaches the thalamus. Few other tactile fibers have a synapse in the posterior horn. They then ascend in the dorsolateral funiculus to the lateral cervical nucleus at C1-C2. The fibers then decussate and join the medial lemniscus. Thus, tactile sensation reaches the opposite thalamus through different routes. This accounts for the poor localizing value of touch in spinal cord disorders and is lost only in extensive axial lesions. The touch sensation from the face will reach the principal sensory nucleus of the trigeminal nerve. It crosses over to the opposite side and ascends along the medial lemniscus as the ventral trigeminal tract. It ends in the ventral posteromedial nucleus of the thalamus. The ventral trigeminal tract also contains fibers from opposite spinal nucleus of trigeminal nerve that carries pain sensation of the face. Some fibers will not cross to the opposite side and form the dorsal trigeminal tract. The ventral and dorsal trigeminal tract is also called the trigeminothalamic tract or trigeminal lemniscus or quindothalamic tract. Pain and temperature. The superficial pain sensation arises in nociceptors, that is the free nerve endings in skin and mucous membrane. Thermoreceptors for heat and cold sensation are free nerve endings in the dermis. Pain and thermal sensation are carried along small myelinated A delta and unmyelinated C fibers to the dorsal root ganglion. First order neurons in dorsal root ganglion pseudounipolar cells enters through the lateral part of the dorsal root to reach the Lisayer's tract, where they ascends for one or two segments. The axons of Lisayer's tract enters the posterior gray horn and synapse in the laminae 1, 2 and 5. The second order neuron crosses to the opposite side through the anterior commissure. It forms the lateral spinothalamic tract which ascends through the spinal cord and brainstem to reach the opposite thalamus. In the past, anatomists thought that the anterior spinothalamic tract carried crude touch and lateral spinothalamic tract carried pain and temperature. Current evidence suggests that all these modalities are carried in both tracts together called the androlateral system. The fibers from the sacral area are arranged most laterally in the lateral spinothalamic tract, followed by lumbar, thoracic and cervical. The cervical fibers, which are the last to arrive while going up, are the medial most. So an intramedullary lesion like syringomyelia will affect laterally placed sacral fibers last. The third order neuron in the thalamus projects to the sensory cortex in the postcentral gyrus through the posterior limb of the internal capsule. The pain sensation from the face is carried by the spinal tract of the trigeminal nerve and synapses in the adjacent nucleus of the spinal tract. The second order neuron crosses over to the opposite side, lie adjacent to the medial lemniscus and lateral spinothalamic tract and forms the trigeminothalamic tract, which terminates in the ventral posteromedial nucleus of the thalamus, from where it is projected to the sensory cortex. The proprioceptive sensation. The proprioceptive sensation arises from the body's deeper structures, bones, ligaments, muscles, and joints. Proprioception refers to either the sense of position of a body part or the motion of a body part. Proprioception has both a conscious and unconscious component. The conscious element is carried by the posterior column and the unconscious by the spinocerebellar tract. The primary receptors for proprioception or kinesthesia is the muscle spindle. The pathway of the conscious proprioception is the same as that of light touch through the posterior column medial lemniscus pathway. The proprioceptive impulses from the head and neck travel through the cranial nerve and end in the mesencephalic nucleus of the trigeminal nerve. From there, they reach the opposite thalamus through the medial lemniscus. Vibration sense or palæsthesia. The receptors of vibration are rapidly adapting mechanoreceptors like Pacinian corpuscles. The Merkel disc receptors and Meissner's corpuscles respond best to relatively low frequencies, while Pacinian corpuscles to high frequencies. Impulses are relayed with the proprioceptive and touch sensation through the large myelinated nerve fibers. They enter the spinal cord through the medial division of the posterior root. It ascends in the spinal cord through multiple pathways, namely posterior column, medial lemniscus, and dorsolateral funiculus. The fibers in the dorsolateral funiculus may be the most crucial pathway subserving vibratory sensation in man. Axons of the second order neurons in the posterior horn ascends in the spinocervical tract in the ipsilateral dorsolateral funiculus. It terminates in the lateral cervical nucleus. Axon from neurons in the lateral cervical nucleus cross in the anterior commissure and ascends to the medulla where they join the medial lemniscus. Though some joint position sense fibers also ascend through this pathway, this divergence of the position sense and vibration sense pathways partially explains the dissociation occasionally encountered clinically between joint position sense and vibration. For example, vibration loss may be worse than position sense loss in subacute combined degeneration. Conversely, for tabes dorsalis, position sense is often impaired with a parietal lobe lesion and vibration preserved. Interoceptive sensations. Interoceptive sensation arises from the internal organs. General visceral efferent fibers are found in cranial nerves 7, 9, 10, and thoracolumbar and sacral autonomic nerves. Visceral efferent fibers run with autonomic efferent fibers to the viscera. Cell bodies are in the dorsal root and associated cranial ganglia. They convey visceral sensations such as hunger, nausea, sexual excitement, vesical distension, and visceral pain. They ascend in the spinal cord through different routes. Some ascend in the opposite spinothalamic tract. Some travel in the ipsilateral spinothalamic tract. Some ascend for a great distance in the iliac tract before synapsing with the second order neuron. Others ascend by long intersegmental fibers in the white matter at the border of the dorsal horn, reaching the hypothalamus and thalamus without decussating. Because of the multiple pathways, the localization of visceral pain is not usually exact. The visceral efferent sensation may end in Gims rectus rather than in the parietal cortex. Localization of sensory symptoms. Sensory cortex. As already described, the primary modalities of sensation are often recognized at the level of the thalamus. So touch, vibration, joint position sense, pain and temperature will be intact in a parietal cortex lesion. The sensory fibers are then projected to the sensory cortex in the postcentral gyrus through the posterior limb of the internal capsule. The parietal lobe primarily does cortical sensory processing. The parietal lobe integrates more than one primary sensory modality to recognize a stimulus. Cortical sensation like tactile localization, two-point discrimination, graphesthesia, and stereognosis will be impaired in the parietal lesion. The patient can have sensory inattention, especially with a right-sided lesion. In sensory inattention, the patient can identify sensation when either side is stimulated separately. On stimulating both sides together, only the right side is appreciated. Rarely, lesions of the sensory cortex and sensory projections in the posterior limb of internal capsule can cause a loss of appreciation of primary modalities of the opposite half of the body, as in a thalamic lesion. In that case, the sensory loss may be more in the upper limb than in lower limb, and distal more than proximal, as the area of representation in sensory cortex is more for these regions. Even more rarely, small lesions in the sensory cortex can produce a restricted sensory loss mimicking a nerve or root lesion. Thalamus. Thalamic lesions produce impairment of all modalities of primary sensation in the opposite half of the body, including the face. A small lesion restricted to the ventroposterolateral nucleus can cause hemiparesthesia without demonstrable sensory loss. Thalamic lesions can cause sensory perversions like paresthesias, hyperesthesias, and allodynia. A patient with a thalamic lesion can later develop a central pain syndrome of the opposite side, a condition called Dejerin-Rossi syndrome. Impairment in sensation with intractable pain in the same area is called anesthesia dolorosa. A parietal opercular lesion can produce a central pain syndrome mimicking a thalamic lesion called pseudothalamic syndrome. Brainstem. The touch and pain pathways are well separated in the brainstem and spinal cord. So lesions here can affect one tract, sparing the other, resulting in dissociated anesthesia. For example, a medial medullary syndrome produces loss of fine touch, vibration, and joint positions of the opposite side due to medial lemniscus involvement, with sparing of pain and temperature. Another feature of a brainstem sensory syndrome is the involvement of the face sensation on the side of the lesion and sensation of the opposite side of the body due to crossed over sensory tract involvement. The classical example is the lateral medullary syndrome, where pain and temperature over the face are lost on the same side due to long tract of trigeminal involvement. The pain over the opposite side of the body is lost due to lateral spinothalamic tract involvement. Rarely, a lower brainstem lesion can produce a sensory level on the trunk. Spinal cord. In the spinal cord, the touch, vibration, and joint positions ascend in the ipsilateral posterior column, while pain and temperature cross over and ascend in the opposite side lateral spinothalamic tract. Several sensory syndromes can occur with spinal cord lesions, namely Brown-Séquard, complete transection, central cord syndrome, anterior spinal artery syndrome, conus cauda, etc. All of them are discussed in detail in the episodes on the anatomy and localization of spinal cord disorders. Please hear episode 5 to revise that. Lesions of the root, plexus, and peripheral nerves. Lesions of the root, plexus, and peripheral nerves will result in the involvement of all modalities of sensation in the distribution of the particular root or nerve. It is essential to know the dermatomes and sensory supply of peripheral nerves to localize these lesions correctly. These images are given on the episode webpage provided in the show notes. The area of actual sensory loss will be much less than that given in the pictures because of the sensory overlap. A patient can have either positive sensory symptoms like paresthesia or hyperesthesia, or negative sensory symptoms like hyperesthesia in the involved area. Polyneuropathies. Multiple peripheral nerves are affected together in polyneuropathies. The classic example is a diabetic peripheral neuropathy with a length-dependent stocking and glove type of peripheral neuropathy. The sensory impairment starts in the sole of the feet symmetrically. It then ascends to the knee and then appears in the arm in a length-dependent manner. Vibration is the first to get involved, often followed later by the other modalities. Some polyneuropathies have a predilection for large myelinated fibers that carry touch, joint positions, and vibration. Others for small fibers that carry pain and temperature. Sjogren's syndrome, pyridoxine toxicity, cisplatin, and B12 deficiency affect large fibers more. Hansen's disease, Tangier's disease, and amyloidosis affect small fibers more. Large fiber neuropathies are associated with reflex loss and, when severe, with motor involvement. Small fiber neuropathies produce burning paresthesia with no motor loss and preserved reflexes. Nerve conduction study may be normal in pure small fiber neuropathy. Dorsal root ganglionopathy. Autoimmune disorders can affect dorsal root ganglia. The large myelinated fibers are affected more than small fibers. The patient will have paresthesia, generalized areflexia, and if severe, sensory ataxia and pseudoathetosis. It may be associated with malignancy like small cell carcinoma and lymphoma, Sjogren's syndrome, and pyridoxine toxicity. It's been more than 9 months since we started our podcast. The podcast has been downloaded more than 11,000 times from over 93 countries. It is now one of the top 10 international neurology podcasts according to FeedSpot. It brings great joy to see all the hard work paying off and see that people find it useful. Please continue your valuable support and share it with your friends and colleagues. Kindly write a review and provide a rating on the Apple Podcast and Spotify. It will be a big help and will be much appreciated. Thanks for listening to Clinical Neurology Podcast. Kindly subscribe and review if you found it useful. You can follow Neurology Teaching Club Instagram account for exclusive figures of this podcast and visit our website neurologyteachingclub.com for more resources. The podcast and online content are meant for medical education only and should not be used to guide clinical decision making and treatment. You can find more of this podcast on Apple Podcast, Spotify, Google Podcast, or wherever you get your ear candy. It's KD signing off, and until we meet next time, spread knowledge.